and practice of large-scale change. Helen is a professor at Warwick Business School who we've been working closely with, and it gave us a perspective on some of the ways to ensure we were able to have maximum impact with our change programs. That segued quite nicely into a discussion on the work we're doing on electronic patient records across the group, but particularly in Swift and George Eliot with the forthcoming work with Oracle and the Cerner EPR system. It also did allow us to talk about some of the great stuff which is going on, particularly down at Wye Valley, on the use of artificial intelligence. And I would just like to celebrate again the way the team down there, in particular Jane Ives, has seized the opportunities that are arising out of the use of AI to make our teams' lives much easier and a better experience for our patients and their families. Glenn then gave us an update on things going on in the NHS, which I'll come back to a bit later, but showed some of the challenges we still have across the foundation group to really drive a transformational change and better value for money for taxpayers. And then we had an all too short session on talent and succession management across the foundation group. So a busy morning already, but looking forward to the board this afternoon where we've got quite a bit to cover. But I do first of all want to, as it's the first time we've been able to, thank Glenn Burley for taking up the role of National Finance Reset Director for the NHS. Glenn has stepped into the breach with Jim Mackey to try and ensure that the NHS is able to address as effectively as possible the financial challenges it's facing at the moment. So Glenn, thank you for that part of your national service. And I'd also like to shout out and thank Stephen Coleman and Adam Carson, who have been through a process and have been elevated to become acting chief executives for Hereford and Worcestershire and Coventry and Warwickshire respectively. So thank you, Stephen and Adam, for your leadership and forthgoing leadership with the challenges that we face. So we have a series of apologies for absence, not least Pramjit Gill, who is one of our non-executive directors from Warwick University, who's at the moment trapped in India with the problems with Pakistan. So Pramjit, if you are watching this from North India, we wish you safe travels home as quickly as possible. Any new declarations of interest, colleagues? Could you please raise a digital hand? Okay, I can't see any digital hands raised. The minutes of the meeting held on the 5th of February. Was everyone happy with the accuracy of those minutes? If not, could I ask you to raise a digital hand for me, please? Okay, again, can't see any digital hands raised. So we'll move then to the matters arising and the action update. And there's, I think, quite short for this. And the first was for the group performance report for the chief operating officers to present a deep dive into outpatients. And that's been completed and looking forward to that on the agenda. And then the managing directors to ensure the perinatal deaths in comparison to the national mean are included in the performance report. And again, that's been done. Thank you. And then on the emergency department benchmarking, our COOs and CMOs to look into ED waiting times and their relation to mortality and morbidity. And again, that's on the agenda, so we'll come back to that later. Do colleagues feel I've missed anything off of the action list? Fiona quite kindly has asked me to formally thank Ellie Ward for covering the Swift CNO post so successfully whilst Fiona was on a leave of absence. Ellie, you have been an absolute star, and thank you very much. Colleagues, happy to move on? I think I've covered off the points on the big moves and key discussions from the Foundation Group Board workshop already. So without further ado, we'll move on to the Foundation Group performance report and over to the managing directors. Who's going to cover things off first?
I think I usually do, because that's the way that it appears in the report.
It's unfair, Jane. It's unfair. We need to rejiggle things on occasion, but over to you.
That's fine. That's fine. So as usual, I'll cover something I'm really pleased with, something I'm really watching carefully, and then a concern which I'll spend a bit more time on this month. So in terms of things that are going well, it's really pleasing that the cancer standards for 62 days and faster diagnostic standard were met for the people of Herefordshire and Mid Powys over the last year. So that's really, really pleasing, and some really good work to build on for next year as those standards increase and get more difficult to achieve. So that's been some excellent work. In terms of the area I'm really watching, I think it's mainly around the productivity metrics. I think we've seen some good movement, particularly in theatre productivity, which we sort of struggled with all year, and then all of that work came together in the last quarter, and we have seen that shift of about 5% increase in utilisation in theatres. So we've got further to go. There are others in the group who are still doing better than we are. So that's an area there that we're looking at improving further. And the other one is around PIFU. So, I mean, it's quite a big presentation, so I won't use all their dry powder. But again, good to see PIFU really starting to increase, and that's been due mainly to a technical change in our EPR, which has enabled patients to initiate their own follow-up in a way that's really safe through the digital electronic patient record. The area I'm really concerned about is urgent and emergency care. Our performance has deteriorated in the last couple of months, with longer ambulance delays outside the ED and a significant number of temporary escalation spaces still being used. And the CMOs will cover some of the quality impacts of that on patient outcomes, but it has a financial impact as well in terms of the number of extra patients that we're having to look after in the acute hospital over and above our bed base. So the improvement approach to that is threefold, but it is absolutely the highest priority that we've got to improve UEC performance. And as it's our highest priority, that's the way that we're treating it, and so there's a lot of resource and attention being given to it. So the first is, we found out yesterday we've been awarded some national capital, which should expand the amount of space we've got for SDEC and assessment space in ED. So those are things that will help, but that will come through over the course of the year. But in two big areas, we're working on process without any change to the environment. The first is working really closely with GPs on the neighbourhood health model. So that's about how we ensure that we keep more patients being cared for at home, and so not needing to visit the acute hospital. There's been some national guidance around that. We're doing pretty well already on some of that. But the area where we really need to focus is the multidisciplinary team working in our neighbourhood. So we say we're working very closely with local GPs, and we're hoping to have a new model up and running and in place by August, which should see more patients being cared for at home. And then the second area is really about how the hospital itself works. So we're running some quite large-scale clinical engagement events over the course of this month to really reset the way that urgent care pathways work in the hospital, from the front door right through to the back door. So we are anticipating that we will have some changes to the way that teams work as part of that piece of work. So we will brief you on that as the learning comes out from those. But there's a need for us to work on all parts of the urgent emergency care pathway, and so that's what we're really focused on over the next few months.
Right, super summary. Thank you, Jane. We'll come back to questions and perspectives at the end of the 4MD introductions of the performance. So I think on that basis, it's over to Adam next, please.
It is indeed. Thank you, Russell. I want to start with elective performance. As similarly to Jane, I do good concern and area we're watching. But elective is my first area. I wanted to highlight the really good performance over winter during a period that has been extremely challenging operationally. The Trust have managed to keep up the levels of elective activity, which has been fantastic, a testament to the work of the team. I think despite the pressures we've seen, the high levels of occupancy in the hospital, we've managed to ring fence and maintain our elective beds and keep those activity levels up. You'll see that's supported by a number of other measures in the report, particularly for our outpatient services that support that. So in the last month, our patient-initiated follow-up rates have been really good, and that supports that productivity and discussion, giving patients the opportunity to choose when to come back to us rather than calling them back routinely. That's really supporting capacity, really supporting our staff work in those more modern ways and meet the needs of our patients differently. In terms of an area of challenge and an area I'm really concerned about, I have to talk about cancer performance. I think this is the area that concerns me most at the moment. We've seen some really significant oncology wait times. We are not where we want to be in terms of performance. Clearly, we are not responsible for all areas of the pathway, as we've talked about here before, but there has been a lot of work in Coventry and Warwickshire over the last year to develop a shared approach to management of the cancer pathways, and indeed over the last few months we've been recruiting the clinical leadership team to support that work. Despite that, there hasn't been an improvement in performance, and I think it's been compounded over the last month by some vacancy issues and some sickness issues across the pathway. Not just staff that work in Swift, but particularly staff that work in UHCW who provide that oncology support. I think there is significant planning work yet to be done in this area. So the team is in place, the conversations are happening. We really week to week are managing and on top of cancer performance, but it is a real area of concern. And as a system, we do need to continue to drive this forwards. In terms of the area I think we're being really watchful of, I want to highlight UEC urgent care performance. So as an organisation, we have seen deterioration in our performance over the last year. I think we need to see that in the context of the significantly increased demand we're seeing on urgent care services. We've talked here about intelligent conveyancing in the past, so that's ambulances from other areas coming to Swift. We have seen a reduction in that in the last month or so, but we've seen a really considerable increase over the last year of what we call walk-in patients, so patients who bring themselves to the Warwick Emergency Department. And that is really having challenges on our capacity, the occupancy in our hospitals, and the flow and the wait times. We are not where we want to be on that, and we are continuing to drive work there for improvement. We've done a considerable amount with our community teams to address the demand before it comes to us effectively, and we've done a considerable amount of work on discharge and getting people out of hospitals safely, quickly. But we are stretched for bed capacity at the moment, I think, as we're seeing across the group. We have put in a bid for national funding to support some estates work, which will help improve our capacity in the emergency department and for our front door services, our same-day emergency care services. And we are hoping to hear whether we've been successful in that and able to plan the next step soon. But I think given the demand increases we've seen, it's partly about staffing, which we've addressed by putting additional staff into our emergency department. But we are now at the point where our estate just can't cope with the number of patients we're seeing. So I think that has to be our next step to address.
Thank you, Adam. Just before we move on, just for clarity, and if I get this wrong, please do correct me. The oncologists, when someone has a cancer and comes to Warwick Hospital, the oncologists they see are provided by UHCW. but the oncology support services, like the provision of chemo and everything else, is provided by Warwick or Swift. Is that a broad description of the way it works?
Yes, I mean, there are some slight intricacies around the edges, but broadly that's how it works, yes.
And our problem at the moment is more around the availability of oncologists rather than the support services. Is that correct?
Yes.
Okay, super, thank you. So we'll come back to questions in a wee while, and then I think we're over to the George Eliot. Catherine, over to you.
Well, thanks, Russell. I'll just run through the metrics as they appear on here. You can see that that is our worst for our performance in living memory. I don't think we've really got as low as that in the past. They can see from the graph that accompanies that our 4-hour performance has been going on a downward trajectory over a number of months. We talk often about the root cause of that being overcrowding in the emergency department due to flow through the organisation. But I think in particular what's seen the deterioration is overnight not being able to see even those patients who are being discharged from the emergency department in a timely fashion. So the teams have really been working on that, and I'm pleased to report that seems to be bearing fruit, and that's picked up quite considerably over the last couple of weeks. But the challenges with the number of medically fit for discharge in the hospital remain. I am pleased to report, Russell, for the first time in months, some positive steps in that regard, mainly due to a conversation by 2 members of staff, one from our complex discharge team, the other from Swift Community Services, about considering how we could do things in a different way, and actually having some positive conversations this week with colleagues in the ICB and in teams outside of George Eliot about how we might do things a little bit differently to use our resources better to try and address this medically fit for discharge problem. So I'm not saying we've got the answer yet, but the right sorts of conversations are happening. And based on the conversation we had this morning with Helen Bevan around the power of engaging people at all levels through the organisation, that's what really encourages me about this conversation, that we're not pushing people to do things they don't want to do, but enabling people to do the things they know are right for patients. If I look then at the sickness levels, whilst that has improved from a high of 6% in December, at 5.3%, that's still significantly higher than the target of 4%. So there's a lot of work going on around reducing sickness rates, which is driving temporary spend in the organisation and contributing to some of the financial challenges. Cancer for us, like for Jane and Adam, is also a concern. I think you'll see that there's variability in the performance around cancer, particularly around the faster diagnostic standard. And whilst that is almost at the target, other people are moving ahead of us in terms of that. That's predominantly driven by demand management. But there is more that we need to do in order to pick up our cancer performance for those patients at an anxious time. In terms of RTT, we've got a significant challenge this year in order to meet the target set for us nationally over RTT. And I think you will see in terms of the number of people waiting over 65 weeks that we've seen an increase in that. We had eliminated that in September of last year, had no patients waiting over 65 weeks. And I think some of the challenges around the messages around funding and trying to balance hitting our financial numbers at the end of the year versus the need to deliver performance collided a bit towards the end of this year. And you'll see that also in our ERF figures, that whilst outpatients is doing extremely well, we saw a bit of a dip towards the end of the financial year in terms of outpatient and day case performance. So we need to get back on that in order to deliver outcomes for patients. What I do want to draw your attention to is the improvement that's been made in theatre productivity. And if you look at the graphs against the numbers on the George Eliot slide, you'll see there's been a slow but steady improvement in theatre utilisation rates, capped and uncapped, and in our PIFU rates. And whilst we might not be the best in the group at PIFU, you can see that there's been a significant improvement. And I would like to thank colleagues from across the foundation group, where there's been learning shared between the operational teams. But it's pleasing to see that that is improving. And I think based on our ERF performance last year, that's a strong foundation in which to build from for elective performance in the coming year. Thanks, Russell.
Thank you, Catherine. Very comprehensive. And finally, Stephen.
Yeah, thanks. And a lot of similar things. So I will go through ours. I'm going to focus particularly on urgent and emergency care, which again has been historically an issue for the Trust and continues to be. We have seen some reduction in our protracted ambulance delays, but that's still not where we want it to be. The bit to update the board on is around our tier 1. So we had our initial tier 1 visit, and there we've agreed there are 3 areas that they're going to focus on. So one is internal to us, which is processing around ED, but the other 2 are system focuses. One is around a frailty pathway for community primary care and the acute element, and the other is around community hospital length of stay. Internally, what we've done is we've set, and we'll have that by the end of the week, is a 30, 60, 90-day plan to improve rapidly. But the other bit I wanted to talk through is the work that we're doing with partners to try and improve flow. So whilst what we're seeing within both hospitals are a length of stay for those that we would describe as simple, so they're not going home with anything else, we're just discharging them. We've got a length of stay of 4 days, which is actually where we kind of need it to be. The ones that are more protracted are where we get into they need something else. Now, it's not always the pathways that we talk about in terms of either Pathway 1 domiciliary care support or Pathway 2, which is community hospital support, and Pathway 3 complex community hospital support. There's also a lot we're trying to do with partners around just interface generally with community and local authority, where it could be something quite simple that they need, but it seems to be we've got a bit of a protracted process at the minute. Sarah's been leading on 2 big streams of work for us that actually are starting to bear fruit, and we've had a conversation with the chair and the chief executive of the Health and Care Trust last night about how we can accelerate it and get that moving. And the 2 bits are, we've got a virtual hospital set up, which historically the Trust had not really engaged with, but Sarah's taken that on. We've got agreement with the ICB. We're really going to accelerate that. And the other is a programme we've got around how we maximise community hospitals, and a programme we've called Out by 5, which is, you know, trying to discharge patients safely, but by day 5, and to get proper rehab in the community hospitals. Again, the results are looking really positive. So we've gone from average length of stay for those patients of around 20 days in the community hospital, 29 days at some, and the stay they've got in the acute bit of up to 2 weeks. We've actually reduced that down to 14 weeks for both, so that's acute and community together. And those patients are getting back home, so they're kind of living proof of what we believe in. The quicker you can rehab, the hospital's not necessarily the best place, and the quicker we can get you out and get you home is better. So there's some green shoots in there that we need to kind of work through how we can accelerate that through. We've got some joint posts with the Community Trust coming through as well, which I think is really exciting. And finally, for me, I won't touch on elective, but just with cancer. So partnership is a bit of a theme. We've done an awful lot of work to reduce the 62-day backlog, and we're starting to see the fruits of that in terms of performance that we see now coming through. But there's a particular piece of work that we have to do with our tertiary partners. So here, probably different to some parts of the group, we've got a number of tertiary partners. We haven't just got one that we work with. So we've got Wolverhampton, UHB, UHCW, and some in Gloucestershire. And we're seeing some fragility in some of those. So what we're trying to work through is whether we have a much more strategic and deeper relationships with a couple of them, and just working out what that could look like. And Jane and I have kicked a piece of work off, particularly with Gloucestershire Trust, because I think there's something that we could really do down there. So again, potentially exciting. They were the main bits that I wanted to draw out with some.
That's great. Thank you, Stephen. Good summaries, colleagues from all of you. But in today's challenge at NHS, none of you have talked about the money. So I'm going to go around the table again and ask you where we ended up on the money compared to our original expectations. So Jane, where did you end up on the money down at Wye Valley, please?
Well, I'm going to struggle for the exact number and ask Katie, but we didn't meet the plan that we set out at the beginning of the year by a handful of million. We did meet the plan that we had agreed as part of the system plan, so the whole system came in where it's expected to be, but under delivery of our cost improvement programme by about 6 million is a problem that we are carrying forward into the current year now, and so our target this year is bigger on the basis of we didn't deliver everything we said we would last year, and so that's something that we are pretty determined not to let happen again this year.
Okay, thank you, Jane. Thank you, Katie. 5.6 million deficit. Just try and remember the running order. Adam?
Thanks, Russell. So we broke even, or we just over broke even, £1,000 over break even. We originally had a 1.3 million surplus plan, which was a challenge, a stretch.
But we had to pay for the community recovery service, didn't we, out of that? Yeah. So we took that hit. Well done for breaking even. Catherine?
Yeah, so we had at the beginning of the year forecast a £0.7 million surplus and delivered a £3 million deficit. We also had to make a contribution to the community recovery service, but that does not account for all of that number. This year we are working towards a £6.1 million deficit as agreed with the system.
Thank you, Catherine. And finally, Stephen.
Yeah, and I'm honest, Joe's texting me desperately to say it's draft, it's ordered, so you'd expect that caveat. We had a 5 point, we came in 200,000 better than plan, which was, we had a 5.7 deficit plan, but we came in at 5.5 million.
Okay, thank you. Just for members of the public, one of the things I fully expect to happen over the next few months is a resetting of the financial regime, which will change those numbers. But Swift in particular, breaking even again, I think that's either 12 or 14 years in succession. The only trust in the Midlands to break even is a very impressive performance. Questions and perspectives. Glenn?
Yeah, I mean, as you indicate, Chair, just on that point, some trusts will show they're breaking even, but they're in receipt of deficit support funding. So the intention is to take that out in order to show the true position. I put my hand up on the performance data. So if I could just come back up. So I don't quite understand what the same day emergency care zero length of stay data is telling me. It may be one that we just need to take back either to COOS or to the group analytics board. But it looks like, I think Wye Valley is showing that we've converted a lot into same day emergency care, and that's not happening in the wards now. Whereas the other two reporting, conscious that Swift haven't reported, look relatively flat. It feels like there's maybe an opportunity for us to do more same day emergency care looking at these numbers. But then when I look at length of stay banding, are we really saying that 50% of patients discharged from George Eliot were zero length of stay? Or am I misreading that? Robin, you might be the best person to answer that.
Just trying to find the part in the file where you're looking, Glenn. A moment.
It's page 26 of 151.
Page what, sorry?
Page 26 of 151 in the pack.
I think while I'm finding that, it's fair to say that 50% of the patients discharged from George Eliot don't go home within the same day. I think that's certainly easy enough to say. As always, admin control. Pin me down. Oh, there it is.
Robin, can I suggest you pop the answer in the chat box?
Oh, well, let me have a look and I'll pop the answer in chat. Yeah.
Okay, super. Thank you. Any other questions or perspectives? I would just make the general point to emphasise it in the public forum because it was made this morning. Because of the very, very cold wind which is heading the NHS's way in terms of finances, it is absolutely imperative that through the managing directors and all the EDs, the process of more radical transformation of services based on the experience of best in class in the foundation group is applied at greater pace to allow you to turn around your finances as quickly as possible. And again, I would just shout out again, the AI usage down at Wye Valley is quite extraordinary, the way that is being picked up. And I'm sure it's not being yet seen in the productivity numbers, but I'm absolutely confident it will be so. Coos in particular and finance directors around the group, it will become more demanding of you to explain why you're not doing things if it's being done in a better way elsewhere in the foundation group. Taking on board Catherine's point about it's far better for people to come up with the ideas themselves, but we are in need of some radical transformation on our financial numbers to ensure we don't get into a pickle as the year develops. Colleagues, happy to move on to our deep dive? So I think now with our deep dive, we're into the outpatients deep dive. So again, I'm not sure who's going to lead on this, but over to you.
Thanks, Chair. I'm going to start and then hand over to Robin partway through, if that's okay. I will share my screen.
Thank you, Chris.
Visibility of the slides. So there's quite a lot in here, and I'll try and draw out some key points for colleagues. I think it's really clear from my point of view, there is lots of good work going on across the group around outpatients. And we have all benefited, I think, from being part of the Getting It Right First Time or GIRFT Further Faster programme, and really embracing the opportunities, I think, sometimes in different ways, but definitely in terms of learning from each other as part of being part of that group. The metrics in this deck are clearly not the whole story about outpatients, and the last part of the pack will demonstrate some of the other bits that we will be working on, or opportunities for shared learning in the wider forums going forward. If I just move through the bits we have pulled out to start with. So the first bit here is about clinic utilisation, in terms of how well we're using the clinic templates that we've got in place at the moment. So on the left-hand side, clearly, broadly, good clinic utilisation, well above 80% in 3 of the 4 organisations, and some work for George Eliot to do in terms of understanding, I think, in terms of understanding that number, but then on a data point of view, that's where the most opportunity is. But on the right-hand side, even with that good utilisation, in terms of where we sit at the moment around getting to the standard we expect around first outpatient appointments under 18 weeks, we have all still got work to do. So some of that will be about how we use that clinic, how we use those clinic templates differently in order to get to the compliant plans that we've all submitted. So in terms of things that we're sort of sharing in terms of learning, I think pathway analysis in terms of really understanding the number of outpatient appointments, the number of touch points that patients have in specialties, and more importantly, the variation even within organisations that we see in some of those pathways, which is part of the pathway analysis work, and how we use patient-initiated follow-up that Robin will touch on later in more detail, so that we can potentially enable patients to manage their own healthcare in a way that suits them by using patient-initiated follow-up, but then that would release capacity for us to see more patients in hospital who need a new appointment to reduce those waiting times for patients that we haven't yet seen. Also really mindful about patients who are waiting for follow-ups and ensuring we've got sufficient opportunity for those patients to have their needs met. And the other bit really is about how we're going to bring some rigour around outpatient booking. So in the theatres and inpatient world, we have a process that most organised NHS trusts is known as 642, where we look 6 weeks ahead, 4 weeks ahead and 2 weeks ahead at how theatres are utilised in terms of the booking. And what we're doing now is implementing something similar for outpatients, and how we can, more work to do in that space, but maturing of that initiative so that we can be even more productive in terms of how we're making sure we're optimising the patients that are in our clinics. The other bit that links to that, though, is about the number of patients that we do plan to see on clinics and the variation there is between some organisations in that respect. Broadly speaking, the work that we've done, actually at a specialty level, we're broadly fairly consistent across a number of specialties, but there is opportunities in some specialties that are set out on the screen. You know, say for example, Wye Valley and Worcester are consistent in gastroenterology, but we are both lower than those at South Warwick and in George Eliot, and possible improvements in Wye Valley around gynecology. But I think it's good to see that we are broadly all consistent in terms of what those clinics look like in a number of specialties. Some work to do though in terms of the alignment of the appointment numbers, if we just move us on, and in terms of how we use those clinic templates, learning from some of the further faster work, and how we can benchmark not only across the group, but also with national colleagues in terms of, because there is national benchmarking data collections that have been done as part of this work through the GIRF programme. And the other bit for me, I think, is how we align some of those clinic templates and our expectations into job plans for our consultant colleagues and the workforce that are seeing patients, and how we can potentially benchmark and at least standardise some of that across the group as a real opportunity going forward to make sure we're all optimising and making the most use of that really valuable resource, and also making sure that we can enable our patients to be seen in as timely a manner as possible. And then bits about how we might be able to do things differently that might impact on an average number of appointments, but might enable patients to have fewer contacts. So, for example, we may see fewer patients in a one-stop shop clinic, but actually it might reduce the number of appointments they need overall. So again, enabling us to be more productive, and also enabling the patient to have reduced number of visits to hospital, which clearly is a good thing for them. And then lastly from me is talking about DNAs or do not attends. Again, some variation across the group. I think it's fair to say that generally most of us have seen a reduction in the percentage of patients that have not attended, in terms of those, what that then means in terms of reducing the number of wasted appointments where we've not been able to see a patient or use that slot for somebody else. It has been an area of significant focus nationally, but also for all 4 members of the group in terms of the work we've been doing. Particularly thinking about opportunities though, there are still some opportunities as set out on the slide in a certain number of specialties, but I think in essence there are still opportunities in almost all specialties across the group to some extent in terms of reducing the number of patients and how we enable patients to attend when they need to attend, because that's clearly the best thing, is to make sure we're using the slots for those patients that really do need to see a doctor or a nurse or other healthcare professional. But in terms of some of the work we have been doing, so there is two-way text reminder services in some of the organisations, so how we are communicating to remind patients about their appointment and giving them the opportunity through that two-way texting service, not only to remind them about when their appointment is, but to give them the opportunity to say actually they can no longer make it, so we can reuse the opportunity for patients. And then doing some work with volunteers and with members of staff about how we're contacting patients, so where we think they have either a history of missing appointments, or where we've got particular specialties where we have high percentage of patients who don't attend, actually using the volunteers in all our organisations to make those contacts with patients on the telephone to really encourage them to attend, or to give them the opportunity again not to attend where they don't really feel they need to or want to, which gives that more personal touch rather than just the text service that has existed. And I think it just brings an added benefit to patients, and also I think it's a real valuable service from our volunteers across the foundation group. So that's all I was going to say, Russell, but I'll hand over now to Robin and just tell me when you want me to move the slides on, Robin.
Yeah, thanks. Thanks, Chris. So in the same light, really, PIFU shows that there is variation across the organisations, but I think as the managing directors have already said in their performance summaries at the outset of the meeting, there's some good work going on across the organisations to see this metric develop. And as you can see from the charts on the slides, that each organisation has areas where they are doing better than the others. So George Eliot cardiology, Swift in gastro, Worcester in ophthalmology, and Wye Valley in respiratory as key areas to note. And it just pulls out the fact that, I think as you've said, Russell, already, that there are things that we can all learn from each other. and we need to understand what's driving those variations in each of those specialties and how we therefore standardise that approach across each of the organisations to all gain the benefits as we go forward. Chris, if you move on a slide. So again, leading on that shared learning, all of the Foundation Group organisations have submitted plans to deliver the national target with PIFU at 5%. We are encouraging our clinicians to discharge patients rather than follow them up where clinically appropriate. I think Glenn's previously related to this as TOFU, and to share the learning amongst our clinicians, which is really important in order to see this develop. We're also undertaking some quality assurance on an analysis of specialties where there are high uses of PIFU, just so, again, on that flip side, we can evaluate the clinical appropriateness of the use of PIFU in those areas. And Jane's already referenced some specialties now using PIFU by default, and therefore we can look at effectively an opt-out rather than an opt-in to PIFU. And we also, as Chris has said, are using continue to use the GIRF recommendations and the playbooks to proceed as a group. So just moving on to the next slide, Chris. So in terms of outpatient procedures, again, a similar pattern, areas where each organisation does better than the others. So just to tease some of those out, Swift, better in ophthalmology and respiratory, Wye Valley, better in cardiology, George Eliot, urology, TNO, gastro, and Worcester, highly performing in gynecology. So again, learning from each of the organisations to be picked up. And the next slide just shows some of where those areas of shared learning are, which is take a specialty by specialty approach to the best performance from each area. Ongoing work around the coding of the activity so that we are clear, we're all comparing apples and apples, and also that continued use of the GIRF playbooks and the work from other organisations outside of the Foundation Group. So just moving on to the next and last slide, which is just a summary really of some of the shared learning. And I think I won't run through all of these by bullet point, but what we plan to do, Chair, is to run an internal version of Further Faster across the 4 organisations. So the way we're planning on approaching this with our operational colleagues in our teams is to do a deep dive into one specialty a month that's driven by the productivity dashboard, and particularly picking up on things like increasing on standardisation of clinic templates, use of text reminders and volunteers to reduce the DNAs, as Chris has already said, increase clinical engagement between the organisations, and also to review referrals and discharge after the first appointment so we can identify some further productivity opportunities. And I'd just like to take the opportunity to underline all of this work with the event that a few of us attended on last Friday, the Operational Excellence event that was led by Jane and supported by the MDs and the COOs and other members of the teams across each of the organisations. That was held at Worcester Uni, which underlined all of this really in the way in which we're sharing our experiences, getting our operational teams to develop shared learning platforms so that we can truly start to benefit and harness the skill sets that we have and the data we have across all organisations of what's working well. And happy to pause there.
No, great, thank you. I think one of the things that comes out of the first 2 presentations, and Andy Parker has touched on a little bit in his last comment, is the importance of sharing data and having league tables, and challenging ourselves as to what the league tables are telling us about our relative performance, and making sure we've got the right ego across the Foundation Group to go and seek input from others rather than think we always need to invent it in our own backyard. There's a couple of questions from Robert in the chat box. If colleagues could pick those up, I'd be grateful. Great to hear, Lucy, about the volunteer contact centre down at Wye Valley. So we'll move on to questions and perspectives for a change. Stephen?
Yeah, thanks. I was just following the event that we did on Friday with the operational managers, which I thought was brilliant, we did have a thought, and I do wonder if this is one of those areas about how we get the clinical people around this as well, some of the clinical leads, because it is really stark when you put those graphs up about we all have specialties that are all slightly different, and some of them are running away with it and others aren't. And I'm wondering if maybe we take that away and have a bit of a think about that as an action, because a lot of this, the ops managers can help, but we need if a clinician really gets into it and really drives it. And I think we have that tough conversation about why can one do it and not the other, and what's behind it. So I just think that really comes through those graphs.
No, and I think that's a point very well made, Stephen. And if we can note it, and Jane's saying in the chat box about a meeting occurring after this board, putting me under pressure in terms of time already, Jane. That's what I like. And Glenn?
Yeah, I was going to say something similar. If you look at that variation, it's clear that it's about clinical adoption and practice rather than patient suitability. So I think we have to challenge ourselves on the ability to learn from best practice, and it's all over the group from what you can see based on those specialties. So that would be really useful. One thing I wondered whether we looked at the new to follow-up ratios as well as part of this, because taking the point that Robin made about we shouldn't be using PIFU to follow up patients who don't need follow-up, I think the new to follow-up ratios would also indicate some opportunities for improvement, because the more we can free up that capacity, the more we can take patients off the waiting list by treating them quicker.
Yeah, no, absolutely. Can we make sure we minute that point on the new to follow-up ratio? And any other questions or perspectives? I mean, we talked about Diamond Patients, I think, is a program we've got going, I believe, at Swift. In terms of theatre utilisation, it's that type of relatively simple thinking, but with a big impact that we need to make sure is adopted across the foundation group. As I said, given our financial situation, it will be a case of having to explain why we're not adopting some relatively simple things that can have a big impact. Colleagues, happy to move on to the urgent and emergency care impact on mortality and morbidity. Quite a few slides here, CMO colleagues. So over to you to sort of extract the key points, please.
Yes, thank you. I'll share the slides, though I'm not going to go through them verbatim. It will just help to show. Can you see the slides?
Yes, we can.
Okay, thank you. So the Office for National Statistics found that the longer you wait in emergency department, the higher your mortality risk is. So what we've done as part of this work is to look at the outcomes of patients who are waiting in our emergency department between January to March of 2025. We excluded children who were less than 16 years, and we also excluded those who attended our minors injuries unit. So that left us with 11,000 patients. And what our results show that patients that are waiting more than 12 hours were on balance. They were young, older compared to those that were waiting less than 5 hours in our emergency department. So the average age for those waiting over 12 hours was 71 compared to 57 years for those waiting less than 5 hours. And for those that were admitted into our care, we found that the length of stay was also longer if you waited more than 12 hours. So there was an average of 7.6 days that you stayed with us, compared to 2.8 days if you waited less than 5 hours in the emergency department. And we found that overall, those that were discharged into the care home stayed the longest, regardless of how long they waited in the emergency department. So they stayed between 15 to 20 days. If we then look at the mortality, the risk of dying was 3 times higher for those that waited more than 12 hours in our emergency department, with a mortality rate of 6.3% compared to 2.1% if you waited less than 5 hours. The impact was highest amongst the elderly population, as the average age of those that died was between 80 for if you waited less than 5 hours, and 82 for those that waited between more than 5 hours. And there was a 7-year gap between men and women, with men being 7 years younger. So in terms of what we're doing to try and reduce overcrowding in our EDs and mitigate these findings, Jane Ives has talked about them. So we're aiming to reduce demand, improve flow, and ultimately improve our discharge and reduce the number of medically fit for discharge patients. So I will hand over to Bhaskar to talk about the SWIFT data.
Thank you, Chi. So if you can move on, please. Next slide. Yeah, and the slide after, please. So very similar data. We did a broadly similar piece of same 3-month ED throughput, limiting it to majors and resus of adult population. So very comparable data. What's reassuring is pretty similar numbers, actually. Over 3 months, we throughput about 11,000 patients on those caveats. And the proportion that spend time in ED more than 12 hours, we happen to be a positive outlier in that less than 10% or around 11%, 950 of the 11,000 spend the time in ED that's lasting more than 12 hours. If you go to the next slide, please, Chizo. But as had been found in Y-Valley, the crude mortality rate, with all the caveat that this is a self-selected cohort who have been deemed to be admitted from majors, from resus, do seem to have a greater mortality observed if they spend longer in ED. Of course, we need to add caution that this is not causality. This is a very crude observation of the data, not entirely surprising, and not surprising that it's consistently being seen across the 3 trusts. But it almost kind of reinforces the fact that even more reason that we should try and go a little upstream and see who these people are that are deeming to have to spend that much time and still live 2 or 3 days longer to then die in hospital. And that's the bit I think Worcester will have done the deepest dive. So we have deliberately served the best in terms of the deeper dive coming to the last. But if I go to the next slide and say that from our perspective at Swift, we've asked for a further deep dive based on this observational data in identifying some patient factors that could help us predict their length of waiting and common themes of admission diagnosis, so that we can start thinking on thematic basis of alternatives to spending time in ED, and any operational factors that are predicting this ED wait and mortality, as for example, the medically fit proportion, whether there is a relation between that. And also in Swift's case, because we have a frailty take, albeit between Monday and Friday, I'm very interested in something I will happily bring back to see what difference there is by interception by frailty team between Monday and Friday in the morning versus general medical team on other times. I'll stop there and pass the baton to Naj next.
Naj, over to you.
Thank you very much. So I could just do this very quickly because our findings are very similar to the other 2 organisations that you've just heard from. So if you could just move on to the data slide, please, Chizu. So methodology is similar, apart from the fact that we actually included minor injuries in there, but the trends will still be the same. If you go to the next slide, please. One thing that we must also acknowledge is actually there are small, but patients are dying within our emergency departments, and there's basically 2 groups there. There's one that have had out of hospital cardiac arrest and patients come in and we just certify them. But certainly in the north part of the county, because we have limited access to hospice, we are also admitting patients who are at the end of their life. They're known to palliative care teams, but turn to the hospital for those last few minutes and hours. And unfortunately, that is still happening. We try to make provision within the department by having a specific Bluebell room, which is a quiet part of the quietish part of the department, so they can be, the last few hours are spent in privacy and dignity with their family. But moving on to the next slide is what I suppose the real, what we've heard from other colleagues is the fact that, yes, we know, I mean, the Royal College has been banging on about this for a long time. The longer patients stay in the emergency department, the worse the outcomes. The mortality is higher, the length of stay is higher, but you get into this vicious cycle. They stay in the department longer than usual, and it's those groups that we've heard from: elderly, frailty, patients. They stay in the department longer, their length of stay goes up, flow is impacted, and as flow is impacted, the ED department is congested. So you've got this vicious cycle developing, which we really need to break. Next slide, please. And again, I can only repeat for what colleagues have said beforehand. The link between long length of stay in the emergency department. We also saw, like Chizo mentioned, about patients coming from care homes, them having a longer length of stay, and maybe link with comorbidities, frailty, etc., and also linking that with longer length of stays. So, I mean, we all want to hear from Jules now, because Jules has done more in-depth work on this, because we all prove the same thing. I suppose the next question is, so what can we do about this? It goes back to, I think, some of the discussion we heard earlier on. Can we pick out cohorts within these patients that are coming into the department and move them through the system quicker? I mean, if you come in with a heart attack, you're going to be moved through quickly. If you come with a broken hip, you're going to be moved through quickly. But there's a bigger group of patients who are elderly and frail and come under a general medical sort of diagnosis group, who I think we need to see where we should be trying to get them out of the emergency department quicker, because these are the ones that are having the longer length of stay and are having those increased mortality within our organisation. So I pass to Jules, who's got that sort of more in-depth analysis.
Thank you, Jinaj. Jules?
Thank you, team. Thank you, Chair. And just for assurance, kind of the figures from Worcestershire Acute are very, very similar. The kind of recent run of the figures that we've done to the rest of my foundation group colleagues. So just for context, in Worcestershire, we've done quite a lot of work on this, because I'm sure the kind of board and the public will be aware that this is an ongoing challenge we've had within our urgent emergency care pathways for some time in Worcestershire, and it's something we have obviously been concerned about. So we've undertaken some kind of more in-depth work, which we started back in the beginning of last year. And that was the cohort study that is referenced here, which was 200 patients we reviewed. So again, just for background, so post-COVID pandemic, we know that our EDs have got busier and remain busier, and that's across all groups of patients. It's walk-ins, ambulance attendances, and both the admitted and non-admitted pathways. And that means that a lot of patients are spending a greater amount of time in the EDs, and now including over those spending over 12 hours. The summer-winter kind of split is narrowing, and actually our summer months now are showing higher kind of activity than winter, but the acuity, i.e. the sickness, how unwell people are, and the admission rates still remain higher in winter, which is why winter prep is often the biggest challenge for us as services. So in terms of the work that we've done here, we were aware that we, post-pandemic, were seeing excess deaths in the UK, and we had seen a spike in the number of excess deaths in our emergency departments, which is what triggered this review. And the kind of summary points here of what we found. So it will come as a kind of no surprise, as my colleagues have alluded to, that the majority of patients that fall into this group of what we call our long waiters, so those that stay in the department or long stayers for more than 12 hours, they are more likely to arrive by ambulance, and they also have a longer, or expected to have a longer wait in the ambulance before they actually get into the emergency department. So that retrospective look proved that to us. And as colleagues have referenced, we appreciate these patients often fall into a particular group, and they are often patients that are usually older, have repeat attendances, so tend to have comorbid, so lots of different kind of medical conditions, and they often present with conditions that we call synonymous with frailty, which are linked essentially to, as you get older and more unwell, there are a group of conditions that become more prevalent, and these patients tend to fall into that group. Having said that, they do all they often are unwell, so they are recognised to be unwell, and that's what a News 2 score often indicates, that they are still unwell as a group. So it's not that they're not presenting when they don't need to, if that makes sense. So they're not being deprioritised for that reason. When they get into the emergency department, they do wait longer to see a doctor. They wait longer to receive a decision to be admitted, so for a decision to be made that they need to be admitted. But recognising that there are still 20% of this group, i.e. the group that stay for over 12 hours, that may well be discharged or leave the emergency department before they actually reach bed. This group of patients have more treatments, more investigations. Again, this is not necessarily causation. This may be correlation with the fact that they're in the department longer, so have ongoing care while they're there, which is right and proper. But there certainly is something to be reviewed at or reviewed in that ballpark or in that area. This group also are the group that are likely to be admitted, as I alluded to, under general medicine, which implies they don't have necessarily a condition specific or a condition that is specific to a specialty. Our work did show that, reassuringly, if you have a heart attack or a stroke or a general surgical condition that requires urgent surgery, you will move through the system quickly. But it's the patients that fall into that more general condition group, things like weakness, confusion, things that again are usually synonymous with our kind of older, more frail population. We do know that those are the groups that often have a longer stay, and then also translate into having a longer inpatient stay when they get there and end up being discharged on a complex pathway, i.e. not to their own place of residence. This group of patients also do have a higher crude mortality, which fits with the kind of information that colleagues have already given. But again, we need to be careful that we're not attributing causation to this, and it may be that the patients that it's more a case of those patients that die sadly while under our care are more likely to have extended waits through the system rather than as a direct result of those waits. But that in its own right means that we've got a quality and patient experience kind of deficit really for this group of patients that we need to address. So the so what factor is that we do need to use this information to drive improvements in our services, which is some of the work we've been doing in Worcestershire. We have used this to redesign our general medical kind of services and also to look at what we're doing with our frailty models. We've also looked at some initiatives in order to try and move patients out of their out of the acute inpatient setting earlier in their journey, recognising that that will be beneficial to their recovery and rehabilitation and hopefully will reduce their length of stay and their kind of comorbidity or mortality elements as well. And it's recognising that you probably can identify this group of patients from the onset. You probably can identify them from their ambulance, the kind of the data we get from the ambulance service when they're en route to us. And we need to try and prioritise this group more in order to reduce some of this kind of mortality, morbidity impact and quality experience impact that they are experiencing.
Really comprehensive briefings, team. At its simplest, therefore, we need to ensure over time that we reduce long waits in the ED, which we've all known instinctively, but this is the evidence base to back that up. Getting into the granularity is important as well. Some points made in the chat box. Questions and perspectives, Glenn?
Yeah, I think there's two angles on this for me. I think certainly the one that says the more rapid the treatment in ED, the better the outcome for the patient. There is no doubt about that one. I think the bigger question is the one about whether these patients could have been managed in a different setting. You know, whether it's about outreach services, whether it's about advice and guidance, whether it's about end of life care, actually, for some of these patients, because it would have been better for them to die in their place of choice, which is more often than not home, rather than waiting in a corridor in ED. So I think there's those two angles and obviously a different set of actions associated with each.
No, the point well made, sort of partly picked up by Joe in the chat box, and certainly the work we've done with care homes within our geographies is one to be built on in that regard. Other questions and perspectives? Jane?
Yeah, I guess just one really. One of the things that I do, I chair the end of life programme board across Herefordshire and Worcestershire. And one of the things we've been trying desperately to get in place, and it's now more than 2 years overdue, is a digital respect form. And it has two aspects to that. One is that wherever the patient is, whether they're at home whether the paramedics need to understand what their respect form is, whether they're in an outfit, wherever they are, everybody understands what their respect form says. And we keep being told we are imminently going to get it, and we're not there. But I'm still being told it's going to happen in the next 4 weeks. So I hope it does, because I think the other thing about having a digital respect form would be it would really drive the quality of the conversations for those respect forms, because anybody who's having that conversation then would recognise that it would make an impact wherever that patient was. Rather, it's a conversation, it's a piece of paper, it may or may not turn up at the right place. I don't think there's much incentive for clinicians to really have that really good quality conversation. So I think if we can get that in the next few weeks, I think it could really be truly transformative across our system, because we incentivize the right conversations with patients and their families, so that we can put a plan in place, which for many of those very frail elderly people, their choice would not be to come into ED and say, and I think as Bhaskar said, die 2 or 3 days later in an acute hospital bed. But I think it's a fundamental plank of that we need to have in place, because I think without it, it's incredibly difficult to get the right information to the right person at the right time.
Yeah, it would be great if the NHS app allowed you to fill out a digital respect form. Sarah Rustrick?
Yeah, thanks. I really agree with that point, Jane. I was just going to make the comment that I think it'd be really good if we can get quite quickly off the mark with that, perhaps, and look at what impact it does make. So actually see what improvements it makes, and also where people are conveyed or admitted when sadly the respect form clearly said that wasn't their intention, but the situation changes, how we can capture that so we can put support in place to move the situation forwards, because we all know cases where people are admitted and that was not what their respect form said. So how do we learn from that and make the system better for people and their relatives? So I just think it might be an interesting bit of a research opportunity if it's something new that we're launching.
But if it was on the NHS app, in the ideal world, WUMAS would have access to the NHS app. In the ideal world, care home managers would have access to the NHS app. So if it was possible to do it through the NHS app, it seems to me it might tick a lot of boxes. Naj, then we'll move on.
Thanks. I mean, I think there are very few people that I see actually come through the emergency department who've actually gotten the respect form not to be taken to hospital. I preferred place of care is their home, wherever. But the bigger problem is that those conversations should be happening more and more. There are patients being brought where the conversation hasn't happened. We've missed opportunities in secondary care. There's missed opportunities in primary care. And I think that's where the conversation really needs to go. And then providing the services out there in the community. So we have no hospice around here, but we've got Mary Ann Evans, and they are providing a really good community hospice care for patients that do want to spend their last days at home. So I think it is work that needs to be done.
Yeah, let's make sure we don't lose momentum on this. Stephen and Adam, if we can maybe take away who can be a sort of a foundation group lead amongst the CMOs or whoever to sort of take this important discussion forward. Glenn, then we do need to move on.
Yeah. There's a proposition on that coming through to Group Strategy Committee next time, hopefully, which Martin Sandler is pulling together at George Eliot. So I'll bring that back to CMOs. Okay,
super. Thank you. Need to move forward then, guys. Good discussion, important discussions. And for members of the public watching perhaps this board meeting subsequently, really do think for yourself and for loved ones what you want to do in the twilight of life in terms of where you want your care to be and what you want to happen to you. It's an important thing to think about. This is Dying Matters Week, and if there's one thing we can all be sure of, is we're all going to meet our maker at some point in terms of death. Taxi is a little bit less certain, but we're all going to meet our maker. Okay, so moving on then to the annual safe staffing overview, including the nurse per bed ratio. CNOs, over to you, please.
Thank you, Russell. For expediency, I'm going to present this. Natalie is going to share the slides for me. Thank you, Natalie. And then colleagues will be here to answer any questions that individuals might have. You can just move on to the dashboard, please, Natalie.
Oh, it's very good, this. So can I just stop? We've got an avatar of Natalie on my screen, which I've never seen before, and the slides behind. I'm not sure how you've done that, but it's very impressive, guys. Back with you, Lucy.
Okay, so I'm just going to focus on the dashboard if I start with. So I'm going to start by making an apology. This is our standard staffing presentation. I make no apologies that it's our staffing one, but I will tell you what we're going to do in the future in terms of improving this report moving forward. What I've included in the dashboard this time is we've included the number of funded beds that each organisation has. And then what we've added this time is those additional patients that we care for every day. And certainly our managing directors alluded to that earlier. So what we've included is the number of escalation beds we have, and these are daily averages for the next 3 metrics. The number of patients that we are caring for in temporary escalation spaces, and the number of patients waiting in our emergency department with a decision to admit at 8 o'clock in the morning. So the numbers are there, and I provide this as sort of helpful context because clearly this will drive workforce pressures and staffing implications and demand. And what you can see from this, which Jane already alluded to earlier, is that all of the trusts are working over and above their funded bed base, and with the exception of South Warwickshire, that's a daily average of about 15% more patients than we have beds for. Do you just want to stay on the dashboard? Thank you, Natalie. We are required to provide a return to NHS England, which is called the Safer Staffing Return. You can see that says Safer Staffing Return overall percentage. And what that Safer Staffing Return asks us to do, we break it down by ward level nationally, is what number of staff did we have planned to have and what did we actually have on the day. And what you can see consistently across the board, across the 4 trusts here, is that we're consistently filling over 100% fill rate. And again, that's largely being driven by that increasing pressure, those 15% more beds that we've got open than we're funded for. I want to move on to some of the workforce metrics, if I may. And again, some of our managing directors alluded to some of these earlier. We know that if our substantive workforce provide care to our patients, that the care quality is likely to be higher, patients are likely to receive better continuity, and we know that substantive workforce understand our local systems and processes and therefore are more likely to be more productive and more efficient in terms of providing care to our patients. So ideally, in order to have that substantive workforce caring for our patients, we would look to have a vacancy factor of less than 5%. 5% is a sort of a good national benchmark for vacancies. And what you can see again across the 4 trusts in the foundation group for registered nurses is a particularly strong position in terms of registered nurse vacancy factor. And actually all trusts by March of this year had a vacancy factor of less than 5% for registered nurses, which is really positive. There's more variability across the healthcare support workers in terms of vacancy. And we know that nationally, this is a difficult group of staff to recruit into the NHS and in particular to retain. And therefore, there's more work to do and a focus for us around healthcare support worker recruitment in the forthcoming year. Again, if we were to look nationally at the benchmark for sickness, the benchmark suggests that you should be at around 3.5% to 4%. And what you can see again consistently across all 4 trusts is work to do with staff sickness across registered nurses and healthcare support workers, but mainly with healthcare support worker staff. And that is a particular area of focus for each of the trusts for the forthcoming year. Not surprisingly, there's not a benchmark for maternity leave. But what we do know is that we, across the foundation group, build 1% headroom into our budgets when we're setting establishments. And that's to say that we expect 1% of the workforce to be off at any one time in relation to maternity leave. And what you can see here, again, across the foundation group, is a significantly higher percentage of individuals off on maternity leave, and a particular hotspot at Wye Valley for registered nurse maternity leave. Finally, on the dashboard, there are only a small number of quality and safety measures, and I'm just going to talk about the family and friends test. So what's pleasing to note across the foundation group again is that positive response to the family and friends test questions is that all trusts are consistently above 90%, which is excellent. It's where we want to be. But we know from talking across the foundation group chief nurses that our response rate to that family and friends test isn't where it needs to be, and we want our reach to be much greater moving forward. I'm not going to go through each of the individual slides in relation to agency reductions. So Natalie, if you could just move me on to the summary slide, please. What is included in the pack for individuals to read at their leisure is just each of the individual's trust performance around this nurse agency reduction. And what you can see across the group is that we've made good progress in all 4 trusts in reducing agency spend in the last 12 months. All 4 trusts have been working on the regional collaborative around nurse agency reduction, and the collaborative's aim clearly is to reduce spend, create better value for money by making sure that agency shifts and provision are provided at NHS England capped agency rates, eliminating the use of high cost off-framework agencies. And what you can see is good progress across the group, but some parts of the group moving faster, doing better sooner, and therefore a real opportunity for us to learn from one another and share best practice across the group. The regional collaborative's next steps will be to focus on bank rates, and we will all participate in that. And what you can see from each of the individual trust slides, that we've all set ourselves and met the national ask in relation to setting our targets for agency and bank reduction for 25-26 in line with the national ask. And finally, from me, just a little bit about the report generally. The board had asked for whole-time equivalent to staff ratios to bed ratios. That isn't easily available. You can do it at the trust level. How many beds have you got? How many nurses have you got? But actually at trust level, it's not particularly meaningful. In order to do some meaningful work, we need to make sure that we're comparing wards that are like for like. And we want to reproduce the work that we did 2 or 3 years ago at George Eliot, South Warwickshire and Wye Valley in terms of nurse to bed ratios. But now that Worcester Acute are part of the group, involve them, and we will ask our deputies to refresh and reinvigorate that work. What that will enable us to do is to compare ourselves against others and to benchmark. And then additionally, what we need to do is focus on the quality outcomes, the outcome measures and the quality metrics in the context of our staffing, so that we can see the full picture and are able to compare and contrast moving forward. Happy to take any questions.
Very comprehensive summary. Thank you, CNOs. Thank you in particular, Lucy. Questions and perspectives. A few comments made in the chat box, worth looking at. Jane's point on maternity leave. Glenn?
So we can't get at the whole-time equivalent per bed easily, Lucy, I think is what you just said, and some further work going on that. But we've got the care hours per patient day captured there. How reliable is that measure? Because when I look at that, it would imply that the trust with the lowest care hours per patient day has the best quality outcomes.
Yeah, it's interesting. So care hours per patient day is the only benchmarkable information available. However, how people count that and capture it isn't always consistent. So it's a helpful benchmark. It's a helpful place to become professionally curious. But I think in terms of the piece of work that we plan to do moving forward with our deputies is to ensure that we're consistently counting that, so that when we do compare and contrast, because I would suggest it's made me very professionally curious around George Eliot. Is their funded baseline establishment not right? Because actually they've got good quality outcomes, low care hours per patient day. It makes me more curious rather than anything else.
Yeah, I can't quite work out the maths, how that works through. Other questions and perspectives? Okay, like lots of these nutty issues, more to go after, more to understand. But thank you, team. We're then now on to the fit and proper persons test and annual compliance. Sarah and Gwynnie, over to you.
Thank you. Gwynnie, do you want me to start and then you add?
Please, yes, thank you.
Yeah. So this report is to give the 4 boards assurance with the compliance against the fit and proper person test framework and the processes that are in place across all of the 4 boards to assess board members' fit and proper person status prior to the annual submission to NHS England. Just to highlight that Swift's internal audit has reviewed Swift's compliance against the framework and gave significant assurance opinion. Worcestershire Acute and Wye Valley's internal auditors have scheduled a review for this financial year, and it's to be added to the work plan for George Eliot's internal audit. So the report's here for receiving and noting, and happy to take any questions. And Gwenny, if you've got anything you want to add.
No, nothing to add. Thanks, Sarah.
Thank you.
Sarah, thank you. Gwenny, any questions or perspectives from colleagues? Okay, so we'll just note it as you indicated. Thank you, Sarah. And then we're on to the Foundation Group objectives in objectives in common. Glenn?
So just a few things to say about this, if I may. In fact, I realised this morning, following that great talk from Helen Bevan, that we're at the leading edge of large-scale change by looking at collaborative initiatives, which is what we have captured here. So what we try and do at this stage in the year is look at the objectives that have been set for each of the trusts in the group and then try and pull together some common themes in them. The big caveat before I do this is that Worcestershire Acute, having just reset strategy, are still in the process of finalising their objectives, but we already know the general flavour of those as the board went through the strategy at the last meeting. So what you will see appended are the other 3 trusts in the group, and then I've made some observations around the opportunities to particularly join up the executives that are leading on those individual objectives. We don't set group objectives. We look at these collaborative initiatives, so we look at each trust deciding what it needs to do and then see the opportunities for improvement. And I pulled out some things on, particularly some of the big moves that we're focused on. UEC pathway improvement, including care closer to home, which obviously we've just touched on in terms of the frailty model. The implementation of neighbourhood health, and I'm making the observation there, if we're going to do that well, it's particularly around the way we bring GPs into those leadership models in the way that we coordinate our community and acute services. There's some work on sustainability. Reducing paper records is a focus at Swift and Wye Valley. I think it'd be good to look at that across the group. I think there's a bit of a gap in terms of focusing on the need to improve sickness, so we pick it up at Wye Valley and George Eliot. There's an opportunity for Swift and Worcestershire Acute to pick that up also. Electronic patient record we talked about in workshop, and obviously we're at different stages of the journey on that one. But the opportunities to learn from Wye Valley and Worcester are there for George Eliot and Swift. The one that stood out a little bit for me as a bit of a worry is there wasn't a great deal of explicit focus on productivity. Now I realise that things like improving UEC pathways, etc., will deliver that, but I think it does need more of a focus. And one of the areas I've suggested that it might be worth us doing some work on, and this would be something that I think we would then take to group strategy committee, would be to look at the community diagnostic centres that we now have in place and that we're building in some parts of the group, to look at how we really maximise the productivity improvements there in two ways. Firstly, just the pure how we manage the activity through those centres, but then also the opportunity for direct access for primary care and how we can improve pathways. So that's an area I think needs a bit more focus. And going back to the point that we touched on earlier around the financial reset, that will change the numbers for the individual organisations. And as soon as we see those, we will need to be working on the 3 to 5 year financial recovery plans in certainly three of the 4 trusts. That's all I wanted to highlight. The individual objectives are there. We'll add in the Worcester ones so people see those once they've been finalised.
Okay, thank you, Glenn. I'm glad you made the comment about productivity, because when one looks at the numbers, it's still the mystery, sort of 6-7 years into the foundation group, that Swift's reference costs start with the 7, i.e. 78, and all the other 3 trusts, the reference costs are around 100. And I would very strongly counsel the managing directors and the acting CEOs to be working on understanding how Swift is able to be so much more productive and what you can copy from. I've got quite high hopes, though, that Wye Valley, in its adoption of AI at the pace it's doing it, will see some interesting numbers starting to come out of Wye Valley as this year progresses. But big opportunities, managing directors and finance directors, to help your executive colleagues come up with more radical opportunities for transformation, given the cold financial winter we're about to hit. Any questions or perspectives to Glenn? Okay, Glenn, thank you very much. We'll then move on to the Foundation Group Strategy Committee report from the meeting held on the 18th of March, which I will take as read. Any questions on that? Bit of a theme in that on AI as well as procurement. Okay, super. Thank you. And so we'll move on then to any other business. Any other business, colleagues, please raise a digital hand. Okay, hopefully you feel it's been a good day. So questions from members of the public or Swift governors who are with us. Sarah, which questions are we aware of?
We haven't had any submitted, Russell.
Okay, and any questions from members of the public who are online would like to raise? Please raise a digital hand or come off mute. Okay, well, lovely to see some members of the public with us. Thank you very much, everyone, for your hard work. I know it's tough for all of us at the moment, but collectively and by sharing experiences together, I'm absolutely confident we will be better placed than almost any other group of trusts in the country to overcome the challenges which Glenn is wrestling with at a national level. I suggest we have a 5-minute comfort break, get back together again at 3:05 and into the confidential board. So see you in a few moments. Thank you very much.